good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. This is Open Mics with Dr. Stites. Today's topic is a little gross, but fascinating, and in some situations, it is life-saving. We're talking about fecal transplants, also known as stool transplants. Taking stool from a healthy person and giving it to a sick person. We'll hear from someone who needed one of these transplants and learn how the process is actually a little less gross today than it used to be, because you don't have to use your own blenders. We'll talk about that in just a moment. But first, let's do morning rounds. The health system is joining an important discussion later today about violence against healthcare workers. Now, this is an ongoing problem, and unfortunately, I think it's an escalating problem across the country. Joining us now is Chad Austin, the president and CEO of the Kansas Hospital Association. The KHA is hosting the panel discussion today. Chad, talk to us a little bit about this problem. First of all, why do you feel like you have to host a discussion around it?
Well, first and foremost, Dr. Stites, it's great seeing you today. But what we wanted to do was to spotlight this issue because it's unfortunately happening far too often in our hospitals, which is violence against healthcare workers. And so, as you mentioned, today's panel discussion, which will involve local hospitals, law enforcement, and the business community, is a great opportunity to highlight the need for the state, as well as the federal government, to take action on this, as well as to educate our community, to let them know that this is happening not only across Kansas, but here in our backyard as well.
So this violence against health workers, Chad, what kind of violence are we talking about? I mean, I know in my hospital, or in our hospital, we've seen nurses and others be attacked by patients. What are you seeing?
Right. It could range from physical violence. It could be verbal violence. What we've seen is that over the last 10 years, the violent attacks against medical professionals has increased drastically. And so within our industry, healthcare providers are 5 times more likely to experience workplace violence than other workers in other industries, according to the U.S. Bureau of Labor Statistics. And so what we're wanting to do is to put some additional safeguards in place. Many of our hospitals have already taken steps to implement more security, have more law enforcement agency available, as well as doing de-escalation training. And this is just another step in terms of trying to combat workplace violence for our healthcare workers.
Yeah, that is really important, I think, because we are seeing it, as well as I mentioned, one of our patients actually threatened not too long ago to say, well, I may shoot somebody. And you're like, no, you can't say that. If you're going to say that, you can't be here. So it is really true. What's it going to take for these changes to take effect in the legislature with the laws?
So we're working with the legislature right now. They're on their April break, and so they'll return next week on April 26th. And one of the bills that's out there that still remains is legislation that will do 2 parts, one of which would increase the penalty against an individual that assaults a healthcare worker. In addition, it would create a new crime of interference with healthcare services, which is very much modeled off of what currently is in statute for EMS services. So it allows us to pursue a crime against an individual when they're taking away the opportunity for a healthcare professional to do their job within the hospital setting.
Wow, this is really important, Chad. Now, there's going to be a panel discussion today. It's going to be streamed live on the Health System and Facebook and YouTube page beginning at 3:30 p.m. Chad, thank you so much for your work in this area. I can't tell you how much those of us here in the health professions and in the medical fields, appreciate that. It concerns me when it becomes okay to attack a healthcare worker. So thank you very much for what you're doing.
Thank you.
Okay, now why would someone ever need a stool transplant? Well, let's talk a little bit about that. It doesn't sound like the topic of conversation at most dinner tables, but it's really important because you see there's bacteria inside the stool, and that bacteria is more helpful than you might think. Inside your gut, there is a complex system of millions and millions of different kind of bacteria, which we call microbes. And it's really important because those microbes, those bacteria, they help us with digestion, absorbing our food, how do we form our stool, and how we stay healthy. Because in a healthy person, that microbiome, that collection of different kinds of bacteria, it is very well balanced, and it happens to you right after you're born. But antibiotic medicine can upset that balance, and when that happens, there's this one kind of bacteria called Clostridium difficile, or C. diff, and it can take over. And the challenge is that when C. diff takes over, it can make you feel really, really sick, you can have chronic fevers, weight loss, lots of cramping and watery diarrhea. You can have 10 or 20 stools a day. C. diff can make you feel really awful, and sometimes it can take your life. Certain antibiotics fight C. diff, but C. diff has this habit, and it's a bad habit because it rebounds and it keeps coming back again and again and again, and sometimes it can become resistant to the different kinds of antibiotics. When we get into that type of spiral, we have to take some more drastic measures. We're going to talk about some of those today. Hey, that is some pretty good animation. I don't know who the narrator was, but that is a pretty good animation, folks. I like that. Well, stool transplants have proven to be very good at fighting C. diff, and joining us now is someone who received a stool transplant, and in fact, the first stool transplant here at KU. Her name is Joyce Funk, and full disclosure, Joyce and I have been working together in the care of cystic fibrosis patients at lung transplant for about 20 years. We know each other pretty well. It's been a long-term kind of thing. We also have Dr. Molly Jackson, one of our outstanding gastroenterologists, it's a big word, GI docs, who performs stool transplants. I want to say thanks to you both for being here. Joyce,
Thank you.
You had C. diff. You were the first stool transplant patient here at KU. Tell us about some of the symptoms you had, and first of all, when was this?
So I originally was diagnosed with C. diff back in August of 2010. The first stool transplant I had was actually in January of 2011.
So tell us about some of the symptoms you had, and how did you figure out that you had C. diff?
Well, anyone who's had C. diff will tell you the symptoms are not subtle. I had some vague GI complaints, had a colonoscopy done, which had turned out fairly normal. Hopped on a plane, went out of town on vacation with my family. About 2 days later, woke up, fevers, terrible chills, abdominal cramping, and then profuse watery diarrhea. It was very clear within about 24 hours that I needed to get on a plane and come home. Subsequently ended up in the hospitalization for the first of what ended up being 4 hospitalizations during that time period.
You were really sick, and it's just another reason you really want a vacation in Las Vegas. I'm just saying, I don't know, it was Vegas, was it, what was it? No. So as we discussed in your situation, like you say, you were hospitalized 4 times, and one time we had gone to a meeting and come back, and you were hospitalized for 2 weeks just to get IV fluids, to get TPN. I mean, you had to go through a lot. Lots of different therapies were tried, and they didn't work. Tell us what that was like.
That was probably the scariest thing for me. Obviously had lots of discussions with the physicians. We knew we were going to try some of the first-line agents first to see if I would respond. And we had a lot of conversation that if I did not have an adequate response to those, that there was always oral vancomycin, which at the time was kind of the big guns, kind of the last resort treatment. And so we got to the point of I wasn't responding to the other therapies, and we started vancomycin. And I was hospitalized at the time, and about 4 days in, I remember thinking to myself, I'm not getting better. And how long is this going to take before I'm going to start getting better? And in conversations with the physicians, it became very clear that the expectation was that I was getting better. And I knew I wasn't getting better, and I knew that there was no other treatments on the horizon. So that was at the point that I knew I was in trouble.
Now, I remember we made phone calls all around the country about trying to figure out what to do. As it turned out, sometimes C. diff is really resistant. People can die from C. diff. I think you were scared around that.
Absolutely.
And in addition, we knew that you didn't make antibodies against C. diff. So there were just a lot of things piling up. We were trying to figure out what to do. I think you're actually one that brought stool transplantation to our attention. How'd you hear about that?
Well, funny story. During my first hospitalization here, my mother and father-in-law were actually visiting, and my father-in-law raises cattle. And he said, Joyce, if you were a calf and you had this problem, we'd do a stool transplant and you'd get better. Obviously, at that point, we had a good laugh. I was thanking God I was not a calf, and time went on. About 2 months after that, one of the microbiologists in our microbiology lab at the time, we worked with a lot in our cystic fibrosis population, stopped me, textbooks in hand, and said, I really need to talk to you. And she had been involved in running a lot of the, not just C. diff cultures, but stool cultures that I had been progressively having over time. And she said, Joyce, you are not growing any of the normal gut bacteria anymore, and I'm really worried you're not going to get better. And I think the only way that we can restore that gut bacteria is through stool transplantation.
She's talking to your father-in-law.
And here's the information. So yeah, it very much came full circle. So that was at the first point that I really heard about it from a healthcare professional.
Yeah, and I remember you and we ended up calling Norton Greenberger, who had been the former chair of medicine for 27 years and retires out in Boston and still doing some work out at MGH at that point. And we talked to him and said, have you heard about this? What do you think? And he encouraged us to keep looking around and trying to figure out how to get that done. So when we first started actually saying, okay, we're going to think about doing this treatment, what did you think? Were you scared about that?
By that point, absolutely not. I had been sick for months. I knew I wasn't getting any better. I had a 15-year-old at home. I was going to do anything and everything to try and get better. So there was no risk I wouldn't take at that point. So that was, at that point there was no fear.
And you were having 20, 25, you were talking the other day, you had 20 or 25 stools a day. You couldn't keep up with your fluid intake. Then you get hypotension, then you end up back in the hospital. At one time you even had a clot from the line. So you had all these complications. And I think, didn't you end up losing 20? I mean, you lost a lot of weight.
Yeah.
It was tough. Those were hard times. What would you like our audience to learn from your experience?
I think probably one of the most important things is to not give up and to stay positive. And I think to also find a focus. My focus for me was my kiddo. I had to get better at all costs. I would have done anything. I would have tried anything. And obviously also to be willing to think outside the box because, we don't know everything. We're going to run into new things as time goes by. And probably the most important thing is to find your health partners and that that you trust and work closely with them to try and find answers.
And just to say, and you got better after that first transplant.
I did get better after that first transplant. I clearly remember I was hospitalized at the time. We did it. I was refusing to go back to the room because that was the room I came out of, that I was using the bathroom when I still had what I considered still had it.
Wise beyond
and
years.
I was demanding to be sent home, but I remember as we were driving home, I told my husband that I didn't feel like I was dying anymore.
Yeah, and right. I mean, it happened so fast. I do remember that. And back then, you had to find a donor.
Yeah.
And then, as I recall, you had to blend up the stool yourself. Is that right?
Well, in fairness, we found a donor. I had a really good friend and then subsequently a family member who I'm internally grateful to. We brought in our blender. We didn't actually have to do the blender.
Oh, hospital grade. It was a wedding present, as I recall.
Yes,
so that was a great wedding present. All right. Dr. Jackson, welcome to our program today.
Thank you for having me.
This is a tough story, right?
Yeah, we hear this. I think people who have recurrent C. diff like this, in the end, at some point, you are kind of desperate for something else because the medicines just don't work anymore. And, you kind of get rid of this ick factor, which I think initially people had because you feel so miserable, and this happens.
Yeah, it makes a difference, and I think I remember because we've worked together for so long, and when Joyce is in the hospital for these prolonged periods, sometimes she needs a mental health break. I'm going to bring her charts to do. We'd go through our CF charts up there. Everyone would come in like, what are you doing? I'm trying to help her. But at the end of the day, these stool transplants, as we've learned from Joyce, they're not new.
They're not new. So the history of FMT and kind of the fecal transplants is pretty interesting. It even goes back to the 4th century, ancient China. At that point, they had these fecal oral suspensions, and they would offer it to people who had diarrhea, food poisoning, and they would see improvement. Aesthetically, it got a little bit better.
China?
Ancient China. So back all the way to the 4th century.
So it wasn't her father-in-law who actually revolutionized the world.
It comes, though.
Oh, my God.
So I mean, around 16th century,
And people
it was
drank
a
it.
little bit more appealing. Golden soup, they would advertise it as, and so people would take this again for a lot of different GI ailments. You mentioned the cattle. So really, veterinary medicine started back in the 17th century, where that's called transplantation, when you transplant into animals. But they used it for cattle, for horses, either rectally or orally for animals who were sick at that time. And it's come a long way. Like I said, it's interesting, even in kind of more modern day, 1950s, there was a group out of Colorado. They were surgeons. They were seeing an uptick of patients who had really sick colitis, almost fulminant. You know, they were going to lose their colons, go to surgery. And when they were doing evaluations, they found kind of what this called pseudomembranes. It's kind of a membrane that lines the colon, and that means it's really sick. And the surgeons, the residents, decided to donate their stool. So they blended it up, gave it to the patients they were treating in the ICU, and there was this miraculous recovery. Now at that time, C. diff had not been identified. So we didn't know what was causing this, but years later, C. diff was identified, ultimately found this. But even then, fecal transplant, not known at that point, was being used.
Well, that is an impressive story that it goes back to, I just wonder what they mixed with there. What did you call it, the golden soup?
Golden soup.
A little whiskey, good age, something.
Anything would probably help it out.
Anything might have helped a little bit. So this is an amazing progress, and now there's no more blenders, right? So how do we do it today?
No more blenders. So as Joy said, when we kind of first started all this, we would stock blenders or have someone bring in their own blender and deliver stool. Now we're actually partnering with the Open Biome, which is a national stool bank, similar to blood banks that are across the country. Open Biome is a stool bank who's partnered with the University of Minnesota. So they screen donors, collect samples, and concentrate it. So we are now delivered small cryo bags, and they come in about 60 mils. We thaw that out and draw it up, and that's what we now instill into patients. So it has come a long way.
There's our video of getting it installed. That's remarkable. You probably would have been happy to have been able to do it like that, Joyce Funk, I'm guessing. And sometimes you still have to do more than one.
That is true. You know, overall success rate of fecal transplantation is about 80 to 90%. It's not foolproof, but the nice thing compared to antibiotics is that even if you have a recurrence after, it still has 80-90% success rate.
Yeah, that's impressive. So what's the donation process like? Can you get on the registry? How does that all work?
Yeah, so donation process right now is coming through where we have the Open Biome. And so it's University of Minnesota. They do a pretty thorough screening and have pretty strict criteria. No antibiotics for about 6 months prior for any patient who's donating. Really restricted travel history, no oral medications that they take routinely, really healthy, no medical chronic conditions, no GI disorders or any symptomatology. And they are screened every 3 months to make sure that that is staying up when they give a stool donation. They also have follow-up screening within 14 days and go through a plethora of both blood and stool testing to make sure it's as safe as it can be. You know, technically fecal transplant is still investigational. You know, we don't know everything that needs to be tested. I mean, in 2020, who knew that COVID was going to be here? And at that point, Open Biome and FMT stopped for a period of time because we had to go back and check all of those samples. Now that's part of the screening process again.
So, you know, I've been actually a stool donor for a patient, and I've been able to have fun, go up and say, hey, I've given you a rash of golden soup. That's pretty good. All right, so are there links between gut bacteria and other health problems as well? Because I think, you know, there's been other potential uses for a stool transplant besides C. diff now.
Yeah, that's a really good question. And I think that the data is still emerging, to be honest with you. I think we certainly think that the gut health has a lot to do with numerous GI entities, whether that may be rheumatologic, neurologic, obesity, we don't know. But there are a lot of clinical trials that are going around throughout our country, particularly with obesity, inflammatory bowel disease such as Crohn's disease, ulcerative colitis, irritable bowel syndrome, some new emerging data for the immune-mediated colitis. So, you know, cancer drugs have really grown recently, and we have a lot more focused therapy. But with those therapies, unfortunately, come some side effects. One of those being some pretty significant inflammation of the colon, also leading to diarrhea, abdominal pain, blood in the stool. And this has shown that it could be beneficial. So there's a lot of emerging data, and I think a lot of hope for FMT beyond the C. diff realm.
Well, we know it has clearly worked. And how close to normal do you feel now?
Not completely, but oh my goodness, 1,000% better than I did. So.
And some people do have more of a permanent side effect from this really severe C. diff.
They do. You know, it just destroys your gut flora, and to be able to really recoup that, it sometimes can become impossible without some type of transplant to reinstill that. So there's about 20% of people who will still have long-term irritable bowel symptoms, which can be a change in bowel pattern, some abdominal cramping, maybe some bloating, and that can be lifelong.
Yeah, that's tough because and now we know so much more, so I assume we get to this a lot faster than we once did.
We do, thankfully we do.
Yeah, we don't have to harvest it, look for your wedding blender, try and make sure you've been hospitalized 4 times and then do it. So is that what we're saying?
Yes.
Excellent, that's
we can offer
better.
you this much sooner.
Thank goodness. All right. Well, if you have questions about stool transplants, please send them into YouTube, Facebook, or Twitter. Also email the Medical News Network. The info is there on your screen. Jessica Lovell is standing by to share that with us. First, though, we're going to check in with Dr. Dana Hawkinson, our Medical Director of Infection Prevention Control. He joins us now for today's COVID count, which I hope is continuing to dwindle down.
Yeah, you seem to be good luck, Steve, for sure.
Good luck. That's what everybody says.
Overall, total cases and active cases are decreased. So 26 total, 11 active, 2 in the ICU, and 1 on the ventilator. So we are edging down towards 0. Hopefully we'll get there, but at least into those single digits.
So, Hawk, one big thing that happened last night, the FDA and CDC officially changed their recommendations around the bivalent booster shot. Now you can get one if you're over 65 or have chronic severe health conditions, living immunocompromised after 4 months of your last booster.
Yeah, you know, they really tried to simplify. So they also removed the emergency use authorization for the monovalent vaccine. So all you can get now is the bivalent vaccine. You can receive one of those and then, of course, a booster. But I think this recommendation that they talked about from yesterday's press release is really, just as you said, Steve, geared toward those elderly and those immune compromised. And as an elderly patient, you can receive a second bivalent booster if it's more than 4 months after that first one that you received, which it is probably for most people who have received one, because they would have received it last fall. And then you can receive it after 2 months if you are otherwise immunocompromised. And then they allow a lot of leeway. There is a lot of vagueness saying that moving forward with your medical teams, if you are immunocompromised, you can then adjust a dosing schedule as that practitioner, as that physician sees fit. So a lot of leeway there, but there is that second dose now that's available for those that are elderly and immunocompromised.
You know, Hawk, that's a really big deal, and it is interesting that without the monovalent vaccine now, bivalent sometimes been a little controversial. I think it's safe to say completely safe.
Absolutely safe. And we've had recent studies that were published in peer-reviewed journals, including the New England Journal of Medicine, that showed no increase in cardiovascular events or cerebrovascular events. So the safety continues to be there, and I think that's overall good news as well. And
Huck, the other thing is, even for your initial series, now as you mentioned, monovalent's been pulled off the market altogether. So even if you get your initial series, it's the bivalent vaccination. Yeah, absolutely. And I think that will simplify, and that's what the FDA has wanted to do, is simplify. And again, Steve, this is really data and decisions made in quasi-real time, because they have been able to accumulate data now since the vaccines were rolled out, and of course now since the bivalent boosters were rolled out, and that is all in the context of all these other variants. So overall, yes, we are getting data, analyzing it, and then making, as real-time decisions and changes to the guidance as we can. So I think that shows that the FDA continues to be nimble as well. I thought the other interesting thing they pointed out in the article is that there is still this sort of super boost that you get right after your vaccination. You're still protected against a severe injury or death, but you may even be protected against infection for the first few months after the bivalent vaccination. So for people who are especially immunocompromised, that can be a real win. Yeah, absolutely, and that is a good thing. We have seen that minimal effect of
stopping and protecting against infection. Initially, we saw that it was a great effect. That effect has diminished, but there still is that effect, just as you said, in those first few weeks after or a couple months after recent vaccination to even help and give some protection against infection. So overall, that's good. But really, this disease is really narrowing down and becoming mostly a disease of the comorbid patients. So those with risk factors such as age or other comorbid conditions, but also immune compromise. So we are really able, hopefully, to narrow and personalize recommendations and treatments for this disease to those most at risk.
Yeah, in case anybody was wondering out there, I am not yet eligible for that 4-month shot period, so live long and prosper. All right, Jess, let's see if we got questions out there today. What do we got?
Hey, good morning. The first one is from Jeremy, and it's for Joyce. Joyce, how did you keep your spirits up, managing the mental side of all of this at its worst and knowing that things weren't getting better?
So I think the question is whether or not, Joyce, hey, how did your earpiece fill out? But I can relay the question. Don't worry about it. How did you manage the mental aspect of this, especially when you weren't sure you were going to be able to get better?
That was hard. I can honestly say that. At times I probably didn't handle it super well. I certainly reached out to my healthcare team and had lots of conversations with them, and even saw some professionals in regards to it, because it was really hard to get my hands around. I think it was hard to get my message out there that I wasn't really improving, and so that was a struggle for me, trying to get that message heard, and then just also the struggle of I might not get better.
So yeah, this is over a decade ago, and I just remember at the time that people had said, "Oh yeah, she's going to get better, she's going to get better," and then along the way, I says, "Well, how come she's not getting better?" So, yeah. Jess.
Earl wants to know, as for the donations, can people that are taking medications like gabapentin or medications for seizures still donate, or does that eliminate them?
Yeah, so through the University of Minnesota, that would limit. One of the recommendations or requirements is that you are not on any standard medications. So they really are trying to get the healthiest of healthy people to ensure that we have the best microbiota.
Yen wants to know if excessive use of medications like chemotherapy, drugs, antibiotics, steroids have adversely affected a person's GI health. Would fecal transplant be necessary as a treatment option?
So in the setting of C. diff, that would be an option. So just by being on steroids or antibiotics, certainly that can change the microbiome or chemotherapy, but that doesn't necessarily always lead to C. diff infection. So if someone is having greater than 3 loose stools a day, then that would be a consideration to check the stool. And if it is an active infection, then first they would require some antibiotics. Fecal transplant is recommended after a second recurrence, so technically third diagnosis of C. diff or refractory
Reagan wants to know if probiotics are helpful for C. diff and just for overall gut health, as we hear.
Yeah, this is a really good question and pretty controversial, to be honest with you. Probiotics are everywhere and they're marketed all over the place, but because they are technically a supplement, there's not a lot of FDA regulation, therefore not a lot of clinical trials and data that support it. There has been one study that was recently done that really did not show any additional benefit in probiotics compared to placebo in the prevention or recurrence of C. diff. And right now there's some emerging data that it actually may limit colonization of new gut flora when you're thinking about fecal transplant. So in my clinical practice, I am not recommending routine probiotic use.
I would also add too, in infectious disease, Dr. Jackson and I work together a lot, especially for things like C. diff, and I think she's right. Even I think it's the most recent 2021 C. difficile guidelines do not recommend use of probiotics like that. In addition, if you have other immunocompromising conditions, there is always that risk those probiotics can translocate through your gut and create a blood infection as well. So I would agree with Dr. Jackson's statements also.
And just last question is from Terry. Dr. Jackson, how do you know the donor stool has the so-called good bacteria?
Yeah. So this is a good and interesting question, because the honest answer is we don't necessarily know. We are not sequencing that stool. What we're doing is we are screening, trying to get healthy people who we know don't have comorbidities, BMIs of normal weight, not on any medications, anything to disturb the gut microbiota, and anticipate that that would then translate to good colonization and regrowth in someone who has a sick gut. Right now there's not sequencing being done, though.
We used to think that you need to be a family, or it would be better if you're a family or relation, and maybe you kind of grew up together. Is that still thoughtful, or still?
So for those who are collecting stool samples, I think amongst and not going to a stool center, that is what we used to do. You know, if someone is in the household who has been around C. diff and has not contracted it, then they must have some type of good gut flora that's kind of prohibiting that. And so we were often seeking in-household donors to be that provider.
All right. Well, let's go around and grab some final thoughts today. Now, Joyce, you and I have talked about final thoughts, but I just want to express what I want your final thought to be. I'm just glad you're here.
Well, thank you. I'm glad I'm here too, and I'm obviously eternally grateful to all the healthcare workers at KU that worked with me through this, because this was a long process.
So. It was long and hard, and you were the first. So, yeah. Dr. Jackson.
Yeah, final thought.
Yeah.
I think for the viewers out there, if you have recurrent C. diff or know of someone who does, you know, there are options beyond just the medications, and this overall is a successful treatment. And hopefully through knowledge and discussion, we can get over that ick factor.
Oh yeah, that ick factor. Yeah. Hawkeye, yeah. Icky, no, good stuff.
Yeah, no, absolutely. And I think this is a good time to step in and talk about antimicrobial stewardship, both in the hospital and in the outpatient setting. You know, be careful when you're going to your physician asking for antibiotics like a Z-Pak or Augmentin or anything like that. We know antibiotics can increase your risk for C. diff infection, and nobody wants that. We certainly want to treat bacterial infections if you have them, but in a lot of cases, a lot of things are not needed to be treated with antibiotics, so just be careful and just make sure that your physician's aware of that as well.
You know, this is another example of the intersection we've talked about before: faith, hope, and science. You know, you had to keep the faith and keep trying to work at it. Joyce had to definitely do that, and then the hope to get better, and her own willingness to try something new, and in this case, science, which has helped take us from blunders to now good packs that are easier to deliver than we ever had. It's kind of like the vaccination. You know, you had to have faith, hope, and science. Transplantation, faith, hope, and science, and together we can save a lot of lives. Hey, this has been a great program today. I want to thank everybody for watching. Have a great day. Don't forget to tune in at 3:30 on our network to look at that that hearing with KHA today, because that's a really big deal. Violence against healthcare workers, violence anywhere is wrong. Taking it inside a healthcare facility, man, that's tough. All right, have a great day, folks.
Coming up tomorrow on the Morning Medical Update, a failing heart kept sending one man to the ER until
they put me in a wheelchair and looked at me and said, "How are you still walking and talking?"
I'm Jessica Lovell on the next Morning Medical Update, how an organ donor saved his life and his lifelong mission now, Thursday at 8.
I'm Alexis Del Cid on the next All Things Heart.
I literally felt like I was dying from the inside out before. I could not walk even half a block.
What she thought was an old back injury was far more dangerous. Why half of her body wasn't getting the blood it needed, and the surgery to fix it, Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.